Good morning. Our topic for today is acute coronary syndrome. So, ACS describes a condition where there is a sudden and sudden and decreased blood flow to your coronaries, leading to unstable angina, non-ST elevation MI, and your ST elevation myocardial infarction. So, for the mechanism for ACS, it could be a non-occlusive thrombus, often a platelet plug overlying a fissured atherosclerotic plaque. It could be in a form of a dynamic obstruction, like spasm of an epicardial coronary artery. It could be a restenosis following a PCI. It could be arterial inflammation leading to thrombosis, or there is an imbalance in myocardial oxygen and demand, and it is increased in such conditions such as tachycardia, fever, thyrotoxicosis in the presence of a fixed severe coronary obstruction. So this is an example of a thrombus. And then in next picture would be a lipid rich core with with a break on the fibrous cup. No, there's a plaque rupture. This is what we call the vulnerable plaque. Uh, this one is a plaque erosion and example of calcified nodule. So when you do a angiogram on these patients, 10% of them will have or will show stenosis in the left main coronary artery, 35% of which will give you 3 vessel CAD, 20% 2 vessel, 20% also as a single vessel disease, and 15% will appear as normal or there's no apparent critical epicardial coronary artery stenosis. So when we say vulnerable plaques, they are composed of lipid-rich core with a thin fibrous cap. Ito yun. So patients with non-ST elevation, acute coronary syndrome, or non-ST elevation MI frequently have multiple such plaques that are at risk of disruption. So what are the clinical manifestations? Chest discomfort is described as severe and has at least one of the following three features. It can occur at rest or with minimal exertion lasting for more than 10 minutes. It's relatively recent onset or within the prior 2 weeks. It's crescendo pattern, so it is more severe, prolonged, or frequent than previous episodes. The chest discomfort is described as a severe frank pain located in the substernal region, sometimes in the epigastrium, radiates to the left arm, left shoulder, or neck area. For the physical exam, it may be unremarkable. However, if there's a large area of myocardial ischemia or a large portion of uh, myocardial infarction, you can have diaphoresis, pale, cool skin, sinus tachycardia, you can have adventitious sounds, basilar rales, and hypotension. Anginal equivalents more frequently occur in women, the elderly, and patients with diabetes mellitus. So, in the electrocardiogram, you can have ST segment depression in about one-third of patients. It may be transient but may persist for several days. T-wave changes are more common. So, mas common yung ST segment changes or ST segment depression. But T-wave changes are less specific signs of ischemia unless they are new, deep T-wave inversions that is approximately more than 0.3 millivolts. So the cardiac troponins, troponin I and T, are the more specific and sensitive and the preferred markers of myocardial necrosis compared to CKMB. Uh, this table shows you the possible causes of elevated cardiac troponin, reflecting direct myocardial damage other than spontaneous MI. When you say spontaneous MI, that is a plaque rupture. So you can have tachyarrhythmias, CHF, hypertensive emergencies, and so on and so forth. And this one for the non-cardiac or systemic conditions. So there is a characteristics temporal rise and fall of the plasma concentration of troponins and a direct relationship between the degree of elevation and mortality. So there's a direct proportion between cardiac troponin elevation and mortality. Uh, so this is an algorithm for evaluation and management of patients with suspected ACS. If you have symptoms suggestive of ACS, and if it's possible, your consideration is possible ACS, you do a non-diagnostic ECG, and you will do an ECG. If it's non-diagnostic and troponin is normal, you observe for 12 hours. If there's no recurrent pain, uh, you do stress studies. Okay? And then, if it's negative, you can discharge the patient and outpatient follow-up. However, if you do stress studies and it's positive, diagnosis of ACS is confirmed, so we will go here, definite ACS. Again, if you have by history, it's definite ACS. Uh, do an ECG. Does it have ST elevation or non-ST elevation? Uh, Changes in the ECG. If it's an ST segment elevation, uh, that will be another, we will discuss that later. For no ST segment elevation, you do uh, troponin assay. And then, of course, since there's ST segment elevation, you have to admit the patient. So this is a TIMI risk scoring for unstable and non-ST elevation myocardial infarction. Uh, the 30 days risk of death for ST elevation MI is 1 to 10%. For recurrent ACS, it's 5 to 50% during the first year. No? The TIMI risk score includes 7 independent risk factors. So these are age of more than 65 or age of at least 65 years, uh, at least 3 CAD risk factors. If you have prior stenosis more than 50%, ST deviation, at least 2 anginal events in less than 24 hours, use of aspirin the 7 days, and elevated cardiac markers. Um, what is unstable angina? So it is an acute coronary syndrome without elevated levels of cardiac troponins. It has a more favorable prognosis than those with elevated uh, troponins, such as non-ST elevation MI. So after initial stabilization, either an early or invasive strategy or early conservative strategy can be pursued. Approximately 80% improve with rest and medical treatment over the next 48 hours. In the early conservative strategy, you can do you can do exercise ECG or perfusion scan or pharmacologic stress test. In the Tactics TIMI-18 trial, it shows that early invasive strategy conferred a 40% reduction in recurrent cardiac events in patients with elevated cardiac troponin level. It is not beneficial, however, with those with normal troponins. For the medical treatment, you admit the patient to the hospital, place at rest, sedated, and reassured. Acute MI should be ruled out by doing serial ECGs and measurements of cardiac enzymes, your troponins. IV heparin should be given for 3 to 5 days to maintain partial thromboplastin time to at least 2 to 2.5 times the control. Aspirin dose, aspirin at a dose of 325 milligram per day. Alternatively, you can have low molecular weight heparin like enoxaparin at a dose of 1 milligram per kilogram subcutaneously twice a day. Treatment. For high-risk unstable angina patients, you should also give IV infusion of GP2B3A inhibitors, especially with those who have breast pain and ST segment deviations and or release or marker of myocardial injury such as troponin I or T. You can give beta blockers, calcium antagonists, nitroglycerin, sublingual as needed for angina, IV nitroglycerin in patients with episodes of ischemia that are particularly severe or prolonged. For the medical therapy, you can give anti-ischemic, anti-thrombotic treatments, and you can consider coronary revasc. Bed rest, again, continuous ECG monitoring to watch out for ST segment deviation as well as cardiac arrhythmias. So, again, bed rest, nitrates, beta blockers, or inhaled oxygen in the presence of hypoxemia as part of your anti-ischemic treatment. So, table of medications or drugs given for non-ST and unstable angina. So, nitrates for chest pain or anginal equivalent. Avoid when there is hypotension, RV infarction, severe AS, or patient receiving a PDE5 inhibitor such as your sildenafil. Beta blockers, avoid when there is a prolonged PR interval of at least more than 24 seconds. If you have second or third degree AV blocks, if your heart rate is less than 50 beats per minute, if you have systolic BP of less than 90, if you have shock, LV failure, and severe reactive airway disease. Calcium channel blockers are only given when nitrates and beta blockers are or intolerable or inadequate. So it is calcium channel blockers are preferred only in patients with variant angina. So again, it is avoided when you have pulmonary edema or evidence of LV dysfunction. Especially, do not give diltiazem or veroprovir in that condition. Morphine sulfate when nitroglycerin uh, will not suffice. Again, it is avoided in patients with hypotension, respiratory depression, confusion, and obtundation. Nitrate should first be given sublingually or by buccal spray. If pain persists, uh, you can start IV nitroglycerin. So what's the endpoint? When symptoms are relieved, if BP falls less than 100, or you have dose of more than 200 microgram per minute. Uh, Other mainstay for ischemic treatment is your beta blockers. It's used to target the heart rate of uh, 50 to 60 beats per minute. It's avoided again in acute or severe heart failure, low cardiac output, hypotensions, high degree AV block, just like the second degree, third degree AV block, or PR interval more than 24 seconds, and active bronchospasm. So, for the calcium channel blockers, you can give verapamil or diltiazem. if only you have ischemia after treatment with full dose of nitrates and beta blockers. ACE inhibitors are most evident in patients at increased risk. These are the uh, primary indications for giving ACE inhibitors in MI. Diabetic, if you have LV dysfunction, or those who have not achieved adequate control of blood pressure and LDL cholesterol on beta blockers and statins. So statins, the HMG-CoA reductase inhibitor, uh, the goal is to decrease your LDL of less than 50% from the baseline, or a, to a value of 70 milligram per deciliter. You can add an addition of ezetimibe 10 milligram daily to achieve this goal. Uh, the reduction of LDL has been shown to reduce future cardiovascular events. So for the initial treatment as anticoagulation, you have to have a dual antiplatelet therapy with aspirin, and then either clopidogrel or ticagrelor, an anticoagulant such as enoxaparin or bivalirudin, and can consider GP2B3A receptor inhibitors in high-risk patients, stratified to early invasive strategy. So, okay, for the during hospitalization, again, you can give aspirin and then clopidogrel and anticoagulant. For PCI-treated patients, again, aspirin, clopidogrel, anticoagulant, and GP2B3A inhibitors. For the long-term therapy, again, dual antiplatelet, aspirin, and clopidogrel or ticagrelor. Same with those who underwent PCI. Okay, dual antiplatelet therapy confer a 20% relative reduction in cardiovascular death, MI, or stroke compared to aspirin alone. But it is rated with moderate increase in major bleeding, of increase in about 1%. So for the oral antiplatelet therapy, these are the following medications: aspirin, clopidogrel, prasugrel, and ticagrelor. For the IV antiplatelet therapy, the abscimab, eftifibatide, tirofiban, and cangrelor. For the anticoagulants, you can give unfractionated heparin or fractionated heparin like enoxaparin, fondaparinux, and bivalirudin. Okay? So, the Triton TIMI-38 trial uh, supports prasugrel, which reduced the risk of cardiovascular death, MI, or stroke significantly. However, there is increase in major bleeding, and another benefit is that stent thrombosis was reduced by half. Contraindications in using prasugrel includes prior stroke, TIA, or high risk for bleeding, and it is not effective in patients treated by a conservative strategy. Actually, they are given in patients who will undergo PCI. For the Plato trial, ticagrelor reduces the risk of MI, cardiovascular death, MI, or stroke compared with clopidogrel, who are treated by either an invasive or conservative strategy, and it also reduces mortality. However, there is increase in bleeding, but the bleeding is not associated with coronary artery bypass grafting. So, what are the options, or what are your anticoagulants? Your unfractionated heparin and low molecular weight heparins. For the low molecular weight heparins, The enoxaparin is superior to unfractionated in reducing recurrent cardiac events, especially in patients managed by conservative strategy but with some increase in bleeding. It's second is bivalirudin, a direct thrombin inhibitor. It's similar in efficacy to either unfractionated or low molecular weight heparin. It has less bleeding and yes, used just prior to during PCI or during PCI. The Fundaparidox, which is equivalent in efficacy to enoxaparin, advantage that lower risk of major bleeding, but the disadvantage is it has more incidence of stent thrombosis. So, bleeding, the most important adverse effect of all antithrombotic agents, including antiplatelet and anticoagulants. So, how do we reduce the risk of bleeding? The dosing should be, the following conditions should be considered when you give the dose: the body weight, the creatinine clearance, and previous history of excessive bleeding. Okay, invasive versus conservative strategy. So when we say immediate invasive, that is within 2 hours, it is reserved for patients who have refractory angina, signs or symptoms of heart failure, or new or worsening mitral regurgs, patients with unstable hemodynamics, uh, patients with angina at rest or with low-level activities despite intensive medical therapy, those who have malignant arrhythmias such as sustained VT or ventricular fibrillation. Early invasive, if you have temporal change in troponins or new or presumably new ST segment depression. And by the way, if you have a Grace risk score of more than 140. So, delayed invasive, again, if patient is diabetic, if you have renal insufficiency, if you have EF of less than 40%, if you have early post-infarction angina, uh, if you have PCI, history of PCI 6 months prior, or prior coronary artery bypass graft. And finally, if ischemia guided, it means you have low risk score, negative troponin, and patient or clinician preference in the absence of high risk features. And it means it's the decision of the patient or clinician that uh, they have they just want to have a ischemia guided strategy. Okay, another segment of angina is your Prince-Metals variant angina. So, characterized by recurrent, prolonged attacks of severe ischemia caused by episodic focal spasm of an epicardial artery. It is common among smokers and younger populations. Pain usually occurs at rest, sometimes awakens the patient from sleep, and is characterized by multi-lead ST segment elevation. So, diagnosis may be confirmed by transient spasm following a provocative or spontaneous stimuli like intracoronary acetylcholine or hyperventilation during coronary arteriography. Long-term survival is, however, excellent. Complications, episodes of disabling pain, MI, serious ventricular arrhythmias, AV blocks, and rarely sudden death. So, treatment: nitrates and calcium channel blockers are the main therapeutic agents. Do not give aspirin as it intends to increase the severity of ischemic episodes and the sensitivity of the coronary tone to modest changes in the synthesis of prostacyclin is increased by giving aspirin. So, beta blockers have variable response. Prognosis: during the active phase with frequent episodes of angina, you have in the first 6 months after presentation. So survival at 5 years is excellent. It sometimes it only have a fixed mild coronary obstruction. It's more benign course and non-fatal MI occurs in up to 20% of patients by 5 years. However, you can have serious arrhythmias during spontaneous episodes of pain, thereby having higher risk of sudden cardiac death. So you can, if you survive the infarction on the initial 3 to 6 months period of frequent episodes, there is tendency for symptoms of cardiac events to diminish over time. Thank you.